Welcome to the GIE author interview series. My name is Professor Ian Gralnek. I am at the Rosemont Medical Center in Haifa, Israel. I'm also the Senior Associate Editor for Gastrointestinal Endoscopy. And it is my pleasure to welcome Dr. John Vargo today to this interview series. Welcome.
Thank you.
Dr. Vargo is an Associate Professor of Medicine at the Cleveland Clinic. He is also the Director of Endoscopy at the Cleveland Clinic. And we're going to be discussing your paper today, Multicenter Comparison of the Interobserver Agreement of Standard Endoscopic Ultrasound Scoring and Rosemont Classification for Diagnosis of Chronic Pancreatitis. Got all those words out.
It's a mouthful.
Yes. Congratulations on getting this paper published. Very interesting paper.
Thank
you. Can you tell us a little bit about the background of this study and how you conceived it?
Well, Ian, first I just want to thank Tyler Stevens, who really is, he's my partner, who really was the mover and shaker behind this article, and I'm actually representing him here, and it's a real honor to do that. When we look at chronic pancreatitis, it's very easy for a medical student to pick up chronic calcific pancreatitis across the room looking at a CT scan. The rubber really hits the road when you're looking at milder gradations of it. How do we make the diagnosis when there isn't obvious calcification or ductal dilation? Mm-hmm. Traditionally, there's been a 9-point criteria system used to help us diagnose chronic pancreatitis, and it includes things such as ductal dilation, a hyperechoic duct wall, and calcifications. And usually, most of the studies that have been published have been based on a threshold measures of how many of those 9 criteria are there, anywhere from 3 to 5. Some of these have been based with abnormal imaging studies. Only a few have looked at functional studies such as endoscopic pancreatic function tests. One study by Wallace looked at the classic 9-point criteria and found a global kappa score of 0.45. Now, mind you,
which is pretty low.
Which is pretty low, and it's not a critique against the authors or but that's the way it is in this area, mm-hmm. And that was a global score. It wasn't even a threshold score. So with this kind of indecisiveness, a group of top-notch endosonographers got together and put together a little more of a systematic approach to EUS scoring of chronic pancreatitis. They looked at the criteria and they weighted them. They had major and minor criteria, and they had minimal measurement values for some of the criteria, such as hyperechoic stranding. And in their hands, in their group, they had a very high kappa value of I think it was over 0.8. So we have the old but good, apparently classic system of the U.S. scoring, and now we have the Rosemont system, and now we have 2 systems. Which one is better? And that's really the form thrust of the study. Our study looked at this from a hypothesis-driven standpoint. We had a sample size calculation based on Wallace's kappa value of 0.45. So we were able to say, we got 14 experienced endosonographers from 12 academic centers and based our sample size calculations on that. And what we did was these are all digital. These weren't VHS tapes. Mm-hmm. These were sent to the investigators, and they did their classic EUS criteria, grading on all 50 of these. They were then, at a separate date, sent a PowerPoint presentation of the Rosemont criteria, which they completed, just to be sure that everybody was on a level playing field.
So you try to standardize that.
Right. Try to standardize the evaluation process, and then after they completed this instruction process, they then evaluated the same 50 vignettes, EUS vignettes, with the Rosemont classification.
Okay. What did they find?
Well, what we found, again, our study was powered to pick up a 0.25 difference in kappa value, mm-hmm. so from 0.45 to 0.7. And what we found was our kappa value for the classic EUS criteria was a 0.54. and for the Rosemont it was 0.65, and it didn't make statistical
The difference
significance.
between there didn't appear to be any added value, so to
Didn't
speak,
appear
on
to
the
be-
Rosemont criteria.
Yeah, it didn't
or
appear
at
to
least
be-
in this one study.
Right, and I think that's very important because we determined clinically that a 0.25 difference in interobserver agreement was clinically significant. Perhaps somebody else would have said, well, maybe 0.1 was good enough. I'm not quite convinced that that type of difference of less than 0.25 adds much clinically, to be honest with you.
Okay. What would you say, in your opinion, are some of the take-home messages from this study?
Well, you know, even though we didn't find a difference, I became biased with the Rosemont because I liked the idea of having more measurements used for criteria and weighting the criteria. I think that's very important. We're able to do that during EUS to measure these things, and I think it can systematically define perhaps in the future how we go about describing chronic pancreatitis. I think some of the other strengths of the study was that it was blinded. We had paired measurements and we used digital video. The other thing is we had investigators of various levels of endoscopic experience, and we had those that had done over 1,000 pancreatic EUSs, and we had those that had done between 500 and 1,000. So obviously we didn't have novices there, but when we broke out, we dichotomized those two groups, we didn't find any difference in terms of the interobserver agreement.
What are your plans here in the sort of next line of investigation in this type of area?
I really, you know, a drawback for the study, obviously, is we can't biopsy pancreatica and prove focal chronic pancreatitis or even global pancreatitis. The technology is there, but it's very primitive, and there's obviously risks. I think what we need to look at is the adding other tests to EUS, perhaps endoscopic pancreatic function testing, may fill that void. Maybe it'll be a combination of EUS and EPFT. Maybe it'll be a digital outlay of the pancreas where we're actually using a computer to do some of the measurements for us. Certainly at this point, when we look at both the EUS criteria, we didn't find a tremendous difference in interobserver agreement. Another thing we didn't power our study to look at the accuracy, obviously, and that certainly could be looked at. But I really think that chronic pancreatitis is a whole spectrum, and I think the mild forms of the disease are going to be very challenging to find. It may well be that a combination of EPFT and EUS will be better suited to pick up those earlier cases of chronic pancreatitis until we find out a safer way to obtain core biopsies of the pancreas.
Do you see Rosemont criteria being taken up by endoscopic ultrasonographers?
I do, and I must admit I'm biased, but I do like the idea of using, it gives us more of a systematic approach. Your hyperechoic stranding may not be what my hyperechoic stranding is, but if I say it's 1 centimeter and you say it's 1 centimeter, now we're talking the same language. And I think it gives us at least a platform of uniformity to move from and hopefully do a better job at diagnosing chronic pancreatitis.
Any plans to look at this type of a comparison in community endoscopic ultrasonographers outside of the experts?
That is a very interesting question. It certainly could be done. I wish that we had found a difference and then we could go to the community and find out.
Right.
I think a very fascinating thing is looking at our trainees. And you know, we looked at a plateau of 500. What does it take to get to that plateau? And as you know, with training competency and the pressure on training, is it 200 EUSs where you reach that competency level? I think that as someone who's been involved in training for a number of years, I see that as a particular value-added proposition with this type of study in the future.
Okay, well listen, thank you again for being here. Congratulations on the publication.
Thanks so much.
My pleasure.
Thank you.